Ms. Haritha Bathina. She is a chief clinical dietitian and registered dietitian at JCI accredited Apollo Hospitals, Hyderabad. She's a convener for IDA Telangana chapter. She's been from 2019 to 2021. A faculty at Amity Online University, IGNO, Medversities, multiple universities she's been associated with. She's been awarded the Nutrition Leadership Award in 2020 by IPIN India. And she's been a chapter author for enteral nutrition formula in the book of clinical nutrition and critical care by ISCCM. That's a great achievement. A journal publication on role of oral fluids. She's also done the Indian consensus recommendation at the International Journal of Contemporary Pediatrics 2023 and won a free paper oral presentation award at IDA 2016 as well. Mumbai for paper on types of cereals and impact on postprandial sugar. So probably that is also going to be impacting on today's talk. She's won the Pune chapter award for the case study as well in IDA 2016. Over to you, Dr. Haritha. We really look forward to having a very enlightening session today.
Thank you, Richa, for your for the introduction that you have given me, and thanks to Salome ma'am for having me on this platform today. Nutritionists has created a very good platform where all of us can connect pan-India on various topics of interest to us. I request Vishaka to go ahead and share the presentation so that I can dwell into it right away. Over to you, Vishaka, if you can share the slides, please.
Vishaka, can you please share the slides?
Yeah. Can I go ahead?
Yeah, please go ahead.
Yeah. So good afternoon to all of you present here. For all of us, diabetes is a topic that we are very frequently, encountering in our day-to-day practice, whether you do OP, whether you do wellness, whether you do inpatient management. And knowing what is happening in the current situation is something that's going to benefit each one of us. So I hope this is an interactive session because all of us are already dealing with diabetes on a day-to-day basis. And more than a presentation, it would be wonderful if it can be an interactive discussion that all of us can have. Next slide. Go to the next slide. American Diabetic Association criteria for diagnosis of diabetes is what I will briefly touch on before I actually go into the management of diabetes. Next. We all know that diagnosis of diabetes will primarily be based on three parameters, that is your fasting plasma glucose, the 2-hour oral glucose tolerance test, and of course the HbA1c. More and more we are relying on HbA1c because it gives us a 3-month average. Next. So if I think as a dietitian, the foremost thing that we all have to remember is definitely the cutoffs. You have a lot of population who is now directly coming to the dietitian rather than going to the physician first. They want to manage it, and then they know very clearly that these are the professionals who are going to first help us without medication, and if need be, we can get into medication. A decade ago, this was not the scenario. A decade ago, the scenario was the patient would definitely visit the physician. We would wait for a diagnosis or a clear-cut mention of diagnosis from the physician, and then only we would label the patient as diabetic. But now, as we practice and more people coming to us directly, we need to understand these cutoff values because especially if they are first-timers, they will very clearly want to understand whether they are in the diabetic phase, they're in the pre-diabetic phase, or they're in a stage where they can manage with diet alone or they need medication. So if your HbA1c is anyway greater than 6.5, or the fasting glucose is greater than 126, or you have a random glucose value which is way above 200, or an OGTT which is way above 200. Each one of them could be diagnostic. We could confirm this diagnosis by doing further evaluation. So if you're doing an HbA1c, you could do your fasting and do your post meal and then get a final diagnosis. But each one of them individually also can very clearly tell you probably this person has been diabetic for quite some time and somehow missed the diagnosis. Next. So let me straight go to understand what is the research studies that are there to help us give the confidence that lifestyle does play a significant role. It has as much medicinal value as a drug can have, and appropriateness of using it in different scenarios is what I'm going to present. There are many studies, but these are the topmost when it comes to medical nutrition therapy or lifestyle induced diabetes management over and above the drugs that are available. Next. Yeah. So the first study which every dietitian should have read thoroughly is definitely the DPP program, or the National Diabetes Prevention Program. This has been replicated in various ways nationwide. It is replicated in individual states as well. So if you want to see DPP in Tamil Nadu, you can see a DPP program and look at the population only of Tamil Nadu. You can look at only the population of Kerala, so on and so forth. Next. But let us see what this study was about. Why is it such a landmark study? And what are the learnings that we can take from it? Next slide. Now, the DPP program primarily looked at a population which is impaired glucose tolerance. That means these are pre-diabetic patients. They have not yet been labeled as diabetic. They are not on medication. And they looked at large number of cohort of people, around 3,000 people, who were then divided into three groups. One group was a placebo group. One group got metformin as a first-line medication. The other group just got intensive lifestyle intervention. They wanted to see which one does better. Now, the common understanding always is that anybody who is on medication is going to do better. And they really wanted to challenge this and see what is the impact of giving medication even in a pre-diabetic state, and what is the impact of lifestyle intervention. Next. So if you see this slide, this can be etched in your memory for further reference, where you will see that the blue line is the placebo, so the values are quite high. The red line are the ones where the people, where all of these people with impaired glucose tolerance got metformin, which is anyway the first line of therapy. They had a reduction in blood sugar levels of about 31%. Whereas you see the lifestyle intervention group did much better than the medication group, and they had a reduction of blood sugars of almost 58%. And this landmark study gave the impetus that is required once again about how nutrition can play a big significant role, how lifestyle can be identified as effective as medicine and can be implemented much before drugs can come in. Next. In fact, some of them went ahead and did the 22-year follow-up of the DPP group. So they looked at the same set of patients and wanted to see if they have any benefit of much after the follow-up has ceased, much after the observations or data analysis was happening. So if you, what they saw that the original group, which was in the lifestyle intervention group, they looked at them after 22 years, and still lifestyle intervention had a 25% reduced risk of diabetes, and as compared to the metformin group, which had an 18% risk of diabetes development. So long after the entire intervention was done as well, they seem to have a continued benefit. And that benefit is what we are talking about to all our patients, or what we need to be talking to all our patients. Next. So the next study that I am going to bring your attention is to the Look Ahead trial. Next slide, please. Now, in this slide, in this study, in the first group, that is the DPP group, they looked at impaired glucose tolerance patients. Whereas in the look ahead trial, they looked at patients who are already diabetic, already on medication, and to these people for whom no lifestyle intervention has been introduced. If lifestyle intervention is being introduced quite aggressively, does that make a difference in their management is what they wanted to look at. One of the goals was, of course, to have a minimum weight loss of 7% and a physical activity where the goal was 175 minutes per week over and above the nutritional interventions that they were doing. Next. So the study design was very clear. They divided the population of 5,000 patients, known diabetics, into two groups, where one got the usual medication care. Both got the usual medication care, but one group got the once annual group session or general advice, and there was no follow-up. The second group got an intensive lifestyle intervention for about 4 years with maintenance counseling thereafter, and they wanted to see primary endpoints of cardiovascular death, non-fatal MI, and non-fatal stroke as well. But what they landed up observing also was, next slide. Yeah, this is the experimental. So it was divided into two groups, and that's very clear. Next. Next slide. Yeah. So if you look at the results of the look ahead trial, patients who were diabetics and got an intensive lifestyle intervention over and above the medication that they were taking, it showed that there was a further reduction in HbA1c from 7.3 to 6.6. Now, we all must remember that even with first-line therapy, even with medication, the goal of reduction of HbA1c is 1%. So maybe they've had some reduction. Over and above that, we are getting almost a further 1% reduction by introducing lifestyle. And that is a big benefit that the patient is going to have. Otherwise, the patient probably would have to be on some other kind of an additional medication or additional dosage that was required. Over and above, you see that the weight loss group, intensive lifestyle group, had a very good weight loss of 8.6%. And the group which was on medication alone did not have any weight loss at all. Of course, there were other reported benefits of blood pressure, triglyceride, HDL, also over a certain period of time. Next. Yeah, so I think this slide is self-explanatory. There was a percentage of weight loss of about 8.6% over 1 year, and we all know that when we are doing a counseling as well, to be giving a patient a very realistic goal, we should look at 7% of the weight loss for them to improve their dysglycemia. Next. So 1 year change in the markers of diabetes control, you will see HbA1c came down from 7.2 to 6.6, fasting glucose from 151 to 130. Similarly, diabetes medication also, there was a reduction from 86% to 78% in the intensive lifestyle intervention group, and the one which was on drugs, there was hardly any difference. Next. This is also how this is also to represent how there was an improvement in the risk factor. So whether not only reduction in the glucose percentage, but the diastolic blood pressure, systolic blood pressure, HDL, LTL, all of them, including triglycerides, improved. One of the classic things that you can see in diabetics is the moment you help them reduce their postprandial blood glucose, you will see a beautiful reduction in their triglyceride levels also. Or in fact, if you look at their reports, you can, and if the triglycerides are high, for whatever reason, and the patient is non-diabetic, you know that probably he's in the pre-diabetic phase, or he's already a diabetic, but is having uncontrolled diabetes. Next. So we looked at two studies. One was on the DPP was on non-diabetics or impaired glucose tolerance. The second one, look ahead trial, was on diabetics. Now the third research, which really needs to be etched in all our memories, is lifestyle over in drugs and diabetes. That means the patient has been a long-term diabetic for 10-15 years. He has reached the maximum drugs that he can take. He is at a tipping point where he has the potency of drugs cannot be increased. He needs to be on insulin, or sometimes you also see patients, sometimes, these days you see all the time patients who are already on insulin, yet have a challenge managing their blood sugars and are marked as uncontrolled diabetes. So does lifestyle intervention work at this point of time is what this beautiful study in the British Medical Journal says. It's LOADD. I want all of you to go ahead and browse about it. It's called Lifestyle Over and About Drugs and Diabetes. Next. Yeah. Next, if it does, the entire slide will come. Yeah. This is a study where they looked at patients who are less than 70-year-old. They got about 93 participants who had HbA1c greater than 7%. In addition to that, either they were overweight or obese, or they were hypertensive, or they were dyslipidemic. So this is the cohort that we normally see in your OPD in your hospital. And if somebody has been diabetic for 15 years, 20 years, these are the people who don't want to visit a dietitian, or they feel that if you have been practicing for 5 years, 10 years, and they've had diabetes for 20 years, they feel they know much better and don't need the help of a dietitian to actually help them with their lifestyle. In such a situation, if you do get a person who wants to look at lifestyle intervention, what is the benefit that he might have? Next. Go to the next slide. So in this group, what they saw is even after 10 years, even after 15 years, when a patient's present with uncontrolled diabetes, in spite of being on optimized drugs, if lifestyle intervention was done at any point of time, there is a further reduction in HbA1c of 0.4%. So a 0.5% betterment in HbA1c, where at the point of tipping on to further drugs is a wonderful reduction. They've had some weight reduction. We all know that as the person ages, weight reduction is going to be much slower. But what is more important in the study is the dosage of diabetes drugs were reduced in 13% of the intervention group. And that's a significant observation because they were at a point where they were going to be going on to further drugs or additional drugs or on insulin. Whereas when they brought in lifestyle, they could actually see a further reduction in the requirement of diabetes drugs. Next slide. So I want all of us to really not wonder whether lifestyle is going to be helpful for a patient who's already on medication, already diagnosed with diabetes. We assume that the medication is going to work for them. But actually, you will see that whether the patient is pre-diabetic, already known diabetic, or a long-term diabetic with control. I always had this sense of doubt for me, especially if the patient was on insulin. Then if the patient is on insulin, it is on insulin for a long period of time, why would the doctor refer the patient to a dietitian? I always, when I was younger, I always had these doubts. But I realized that with the help of these studies, we can understand now that at any point of time, lifestyle intervention goes hand in hand, is highly supportive to the medical therapy that they are getting. It may not reverse it for them for somebody as long as 10, 15 years, but definitely helpful in managing them as a more holistic way of managing diabetes. Next. So let us now look at diabetes remission and what information we have out there about diabetes remission. So I'm going to be totally basing it on studies that we have and the impression as to whom we should be giving the hope of diabetes remission and whom we should not be. So in general, if you see the natural history of diabetes management, it starts off with normal glucose and then it goes to pre-diabetic condition, then clinical diabetes, and then the complication. And that's how we've all kind of, seen it evolving over a period of time. But in the past decade or so, we are now able to see that it is going from right to left, where we are focusing on reversing this situation or remissioning from this situation by lifestyle intervention alone. Next. So let us define what is remission so that we are clear about what we are talking and then try and understand whether that is possible or not. So by definition, remission means that you have some degree of weight loss. You have a fasting plasma glucose or HbA1c below what the WHO diagnostic threshold. That means you want a HbA1c below 6.5 on 2 occasions separated by at least 6 months. So you have a value today. 6 months later, you repeated it, still should be less than 6.5. The attainment of these glycemic parameters following complete cessation of glucose lowering drugs. That means once you think you're on remission, then you completely stop your glucose lowering medication, and yet your HbA1c should be less than 6.5. Then only you can label the patient as being under remission. Next. So what is the basis of this remission? If you see, usually evolution of type 2 diabetes happens when there is high fat content in the liver. The liver is exporting the extra amount of LDL, HDL, etc. There is a lot of fat sitting on the pancreas, which leads to beta cell reduction in the beta cell function. However, in remission, we are just trying to reverse this situation where weight loss leads to reduction in fat in the liver, fat that is being circulating and exported out of the liver, reduction in pancreatic fat. In general, wherever there is high fat in any cell, you will see a lot of insulin resistance. So when weight loss happens, there is reduction of fat cells across the body, and that's how the beta cell function improves, and you land up in remission. Next. Different associations have defined the remission differently, but broadly, if you see, all of them are talking about HbA1c less than 6.5 without the help of diabetic drugs, and they should be evident somewhere between 6 months to 1 year. Then only you can define the patient as being in remission. Next. So, of course, we all also want to see whether this has been studied in trials. And one of the best trials that you can refer to is the DIRECT trial, the Diabetes Remission Clinical Trial. It was designed to determine whether a structured intensive weight loss program delivered in a primary OP care setting is viable treatment where you can bring them to a normal glycemia. The aim was to achieve, of course, remission of diabetes, which was hypothesized to follow weight loss of the order of 15 kg. So if you have 15 kg of weight loss, then you have significant reduction in the blood glucose levels, and whether this was going to be maintained after 3 months also. Next. So the initial results of the DIRECT trials showed that, it started in 2014, showed very clearly that almost 46% of the people with type 2 diabetes who received the weight management program in remission. So that's a good number, almost 50%. And 36% were still continuing to be in remission after 2 years. So this was a huge understanding. Almost 50% within 1 year went into remission. That means that is a great tool which a dietitian can remember and say that if you implement your program very clearly, you are going to achieve without fail, and you can base your programs, you base your diets almost which are similar to your DIRECT trial. So all of you can read through the trial to understand what needs to be done in detail. Next slide. However, the participants who were there in that study were followed up for a significantly long period of time to see whether 50% of them who were in remission continued to be in remission or something else happened to them. So at 5-year remission data was available for about 93 people, and it showed that 12 out of the 118, so only 10% in the intervention group were still in remission compared to the 5% in the control group. So you see, remission may not be there forever, especially if the follow-up doesn't continue or the patient that continues to maintain the weight loss that he has had. So the study wanted to see that, and after 5 years, they saw that that 50% reduced to 10% and that 36% reduced to 5%. Next. So we really need to select the population very carefully. We cannot promise remission to everyone. We need to promise remission, especially to pre-diabetics, very young diabetics. So if you have a 25-year-old who's a diabetic, yes, you can promise that person that, okay, let's try with the lifestyle modifications and then only look at medication. Early stage disease, young population just recently being diagnosed with diabetes, lower number of diabetic medications, and a greater weight loss are indicators for remission. Either it is a surgical remission or a non-surgical intervention that you are going to use for weight loss methods. The greatest challenge, however, as all of us understand, is to sustain the type 2 diabetes remission, is maintaining a weight loss and lifestyle changes. Next. So the whole idea is to not select a patient who's been diabetic for a long period of time, has multiple complications, multiple comorbidities, is already on high dose medication and high dose insulin. You may talk about partial remission. You may talk about reduction of medication. You may talk about management of complications better, but you don't talk about complete remission to them. So how do you really achieve this remission? One of the best ways to achieve remission is through a low carbohydrate diet. We all must remember that much before insulin was developed as a form of therapy, reduction of carbohydrate intake was the main treatment for diabetes. Insulin was developed much later. Until then, most of the physicians who did manage to take care of these diabetic patients admitted patients to gradually reduce their carbohydrate intake and better the glucose levels. Next. So how does it really work? If you have reduced carbohydrate intake, it leads to reduced circulating insulin, which again directly impacts reduced liver fat, weight loss, pancreatic fat loss, obviously improving insulin sensitivity and therefore reversing type 2 diabetes. Next. However, we all know that in India, there is no population level acceptable macronutrient ranges which we can stick to. You will see some say 65%, some say 60%, some say lesser. So there are no specific guidelines which all of us are able to follow. Next. More recently, we have the ICMR supported India Diab study, where several of the senior colleagues and physicians have very clearly told us, reinforced what we are thinking, that type 2 diabetes in early stages can be reversed by reducing the carbohydrate intake, increasing protein intake, apart from lifestyle adherence. Next. So you have Dr. Anjana also from Diabetic Research Foundation, reiterating the same thing, that unlike previous studies that have recommended very low carb intake, which is quite unsustainable in an Indian context really, results show that even a modest reduction in carbs does help. And that should be our goal, that we don't want to give a very low carbohydrate diet, but we want to understand where the patient is and reduce a certain percentage of their carbohydrate intake and help them achieve their results. Next. So if before we reduce, we all need to know what is the usual carbohydrate intake of most Indians per se. Of course, we can go state by state, but if you look at the START study, Dr. Mohan and team have just tried to identify diabetics, how much carbs do they eat, non-diabetics, how much do they eat, out of which how much of it is complex and how much of it is simple. So it's a very simple study, but it gives us a certain impression of what is the actual carbohydrate intake before we really look at reduction per se. Next. So according to this study, we have about 64% of the carbohydrate intake, which in general population in India is consuming, out of which about 57% is a complex carbohydrate, which is the good part of it. There are people who are consuming about 7 to 10%, plus or minus 10 of simple sugars, but a majority of it is complex carbohydrates. Next. So if you're really looking at certain guidelines, the India Diab study does give us we have started off with 70% carbs, come down to 60%, come down to 55%. But the study recommendations very clearly show that carbs should be somewhere between 49 to 54%. For ease of understanding and remembrance, we can say 50% of the diet can be carbohydrates, 20% protein, and 25% fat. And that remains there as a standard that we have always practice. So the only reduction is about the carbohydrate content, and therefore that's what we can remember. That means you don't have to go and tell a patient that eat only 30 grams of carbs, eat only 50 grams of carbs. Of the total energy intake, 50% can be carbohydrate intake, and of course all of us agree that it should be carbohydrate, complex carbohydrate. Next. This is pretty much the conclusion that yes, protein intakes need to be looked at. All of us, when we're talking about diabetics, we are all very particular about, even in colleges, we were taught that we should be calculating the carb intake and figuring out what is the carb intake, what is the carb intake at each meal, how much does the snack provide, so on and so forth. But we never looked at the protein intake. Today's need and requirement is we need to look at the total protein. We need to look at protein from each meal, so that each meal postprandial is under control. Similarly, we need to look at the fiber content as well. And that's when we are doing a more true, holistic, balanced macronutrient count for our patients. Next. While on this topic, I thought it is important to touch upon certain myths. There are many myths. But most patients, when you tell them cut down on rice quantity, the first thing that they ask you is whether can I switch to brown rice, or already I'm having brown rice. So I thought I'll just discuss this one particular thing with you. Next slide. There is this very small but simple study on effect of brown rice, white rice, and another third combination where you combine the brown rice with legumes and see what happens to the blood glucose levels. And this was done with Dr. Mohan. Next. So this looks like a confusing slide, but if you focus on it, the red peaks are of white rice. So I'm sure all of you have this doubt that between brown rice and white rice, is there a significant difference? There is some difference. So white rice is peaking more. If you see the black peak, the black peak is only brown rice, whereas the blue one is brown rice with legumes. So what we are recommending is, while you may have switched to brown rice, make sure that your patient is consuming some amount of legumes, dals, or certain protein in that meal to have a better glycemic impact. Next. Next. So the percentage difference in a 5-day average was about 19% lower in the brown rice group than the white rice. But whereas the brown rice plus legume group decreased the glycemia further to 22.9%. So the 5-day percentage change in fasting insulin was also better, which concluded that consumption of brown rice in place of white rice can help reduce 24-hour glucose and fasting insulin response among Asian Indians. And this can be a takeaway. This can help us understand how different grains behave differently and how fiber content of a particular grain or a protein combination with a grain can have a better impact. Next. I'm coming to the last 5 slides of this presentation, where I'm talking about few cases that we normally see in the OPD, which will give you a peek into how you can manage it differently and what are the typical cases that we see and whether it benefits the patient or not. Next. So this is a case of a simple de novo first-time diabetic, 40-year-old male. He was a colleague of mine, basic vegetarian, and when I saw him, his fasting was way above 126, PP was 244, triglycerides were high because of the circulating sugars. HbA1c, I didn't put it here, but it is somewhere around 7.6. So looking at these values, even I told him that, boy, you will need both medical help as well as lifestyle intervention. But he said, see, ma'am, I'm there in the hospital. I have immediate quick access both to the physician and to you. So I would like to try lifestyle intervention alone. And if it still doesn't work after 1 or 2 months, I'm ready to go to the physician. So I left that decision to be purely his and went ahead with the intervention. Next. Yeah, so gave him a very basic, carbohydrate reduction from what he was doing. Next. So if you see after 3 months, I met him first in June, so July, August, September, only with lifestyle intervention. The fasting blood sugar came down to 101. Postprandials, you see, were reduced almost by half from 244 to 115. HbA1c, you see, so beautifully it reduced from 7.6 to 5.7. That means there's a 2% reduction in HbA1c without the use of medication. Triglycerides halved and LDL remained there. LDLs are tough to budge. Now, what is important to note also that he had a good 5 kg reduction from 76, he went to 71. And all of this is pure lifestyle intervention, pure lifestyle medicine, which will give you the impetus to give confidence to the patient as well. Next. This is another case of neglected IGT. That means the patient saw impaired glucose tolerance almost 2 years ago. Fasting was high. Again, when they checked 2 months ago, the fasting was high. They're working executive, homemaker, very busy lifestyle. Therefore, did not focus on, we did not take it very seriously. She started some aerobic activity during lockdown, but did not continue. And then when she checked again, she had a high HbA1c and was diagnosed as a frank diabetic, was given medication and referred to a dietitian. But she still did not want to try the medication and wanted to see what kind of benefit she might have of lifestyle intervention. But this is a case where we should not give her false hope. We should not tell her that, yes, lifestyle intervention will give you the remission, because we can see that being a busy homemaker who's been neglecting for 2 years already is not likely to stick to a very active lifestyle plan. Next. So I'm just giving you a glimpse and impression of different cases that do come to us. So in this case, you see she already had a HbA1c of 9, fasting was 180, and lipids were also on the higher side. And though I gave her a plan, I'm not sure she's going to stick to the plan as effectively and come back with great results. Next. Next. Another classic case that you normally see in the OPD is a pre-diabetic. Here was a senior working professional. Apart from being a pre-diabetic with HbA1c of 6.3, he was somebody who specifically came to see the dietitian after doing routine medical health checkup. The primary concern, all reports were normal except for HbA1c sitting at 6.3, and he was quite an aware individual. His main concern was he was fatigued, tired on a desk job by 3 in the afternoon. So, of course, in this individual, we went ahead and looked at this vitamin D, which was at 19. B12 was within normal limits in terms of the limitation, in terms of the range. However, he had classic symptoms of B12 deficiency, and therefore the correction was done, which helped him quite significantly. However, next slide. However, this was an individual who, though he complained of fatigue, tiredness, low vitamin D, he had a family history and was pre-diabetic, he didn't want to take it very aggressively. So you will have people who come with their own set of goals, and based on their goals, based on their aims, based on how ready are they, we have to create different plans for them. So since this individual, next slide, since this individual mentioned that he had to have a heavy breakfast and go out of the house, as his lunch was always bare minimum, he didn't want to really budge and change on those. We had to do only one meal as a protein first meal, and then help and see whether that has helped. That would help him with both his weight loss as well as his diabetes resolution. Next slide. So this is just a sample of the plan that I gave him. So all I'm saying is, in some patients we do a simple carbohydrate reduction. In some patients we would do all 3 meals as protein meals. In some patients who are not yet ready for it, we would do 1 meal at a time and try and achieve and walk the path along with them so that they are with us with the plan. Next. This is another case. I discussed the lifestyle over and about drugs case with all of you in the study. I got a classic reference of this from one of our physician who's a known diabetic on medication. Fasting was 200, HbA1c was 9. Doctor already wanted to put her on insulin. She was reluctant to go for insulin, and that's when the doctor said, "Okay, I will refer you to a dietitian. See what can happen. I'll give you 3 months time. And then if it still does not work out, we put you on insulin." And that's what she agreed to. And that's how she came to a dietitian. Next slide. So we discussed a lot of things with her, but what I want to bring to the highlight is look at the doctor's prescription. He had already written that give her a 1200 calorie diet, out of which only 50% can be carbohydrates, and give her a high protein diet plan. So there's a very good prescription and a guide from an endocrinologist himself who gives you based on, he's also analyzed the patient and he's giving you a very clear cut answer. And that's why it's easier for us to talk to the patient and say that if you go on a little overboard than this, you're not going to be sticking to the 50% cal plan, 50% carb plan. Next slide. Yeah, you can go to the next slide. In this patient, I did a 2-meal protein diet. So each patient is different. You play around with the different types of diets that you want to give, and you realize that each one is different. One diet which fits one patient definitely does not fit another. This is another overseas client. I did only an online consult with him, but this chart he made and sent. So I preserved it wherein in a month. So he consulted in December, and by end of Jan, he had come back for a second consult. So in these 2 months' time, you see that the last part of it, the HbA1c from 8.7, it went down to 7.6. And this is known diabetic, was overweight, went to a physician in Singapore, and the physician said, "I don't want to increase medication for you. Go lose weight and come, and then we will see if required." So, you see only with lifestyle intervention, in spite of being a diabetic, 8.7 to 7.6. So this is roughly about 1%, 1.1% reduction in HbA1c. And that's the goal which we have when, let's say, there was an additional medication put for this gentleman. The goal would have been 1% reduction in HbA1c, which he achieved simply through lifestyle changes and a little bit of a weight reduction. He lost about 2 kgs weight. From 86, he went to 84. Next slide. So that's about it from my side. I tried putting few OPD cases, which I classically see towards the end of it, to give you an impression about, whom do you talk to about remission? How much remission are you talking about? So, all of us, I think, should not talk about reversal completely. We may talk about remission, but our remission goals for each patient could be entirely different. And that clarity or aims should be very clear between you and the patient. And then you will always be successful with what you are aiming at. Thank you, and over to you, Richa.
Great. It was extremely enlightening, Dr. Haritha. One, to congratulate you on this talk, that you have comprehensively covered all the points, whether it was distribution of the macronutrients you're talking, whether it is the right healthier food choices one has to make. And when comparing different case-based approach that you had shown about how a different case has to be tackled in a completely different manner, which means a lot of personalization also needs to be done. Along with that, the inclusion of fiber intake and how would you be wanting to divide the carbohydrates in the meals is extremely important by also increasing the protein intake. So it was very, very put up in an articulative way and in a very simpler version for all of us to understand and comprehend too. I'm sure everybody has been dealing into diabetes, it being a metabolic disorder, which is, every second person who's coming to you is diabetes. So I would request if anybody has any queries or want to share their experiences in diabetes remission, please, you can put forth your questions also. Do we have Salome ma'am here? Ma'am, would you like to give your inputs on the same?
Thank you, Haritha. Thank you for accepting our invite. Thank you for being there. and thank you for collaborating with Telangana IAPN. We're very happy to have you and for this extensive and very simple presentation for our participants to know which are the different patients which will go for reversal, which will have remission, and how long does it take. It's very important to understand these studies and also select your patients. Also, the lifestyle has been a very great intervention for all types of people, right from the quite many years, say 20 decades. We as a nutritionist are looking at lifestyles, but when we are only using MNT and lifestyle, I think we have not, I mean, in my career days, we have not put down these cases or kept a record how many went into a remission or a reversal, though we brought down the carbohydrate up to 50%. Because I remember in my early days practice of 80s, we were having only one motto, that is to increase the protein and reduce the carbohydrate. And those days we didn't have so many studies, or and of course with so many patients we didn't have anything to put down in a paper. But today we know how important it is and how well you've described different patients who can really be change their HbA1c and reverse or come into remission of diabetes. So I think our participants will be quite clear into how they should go about with lifestyle, with the right MNT of carbohydrate, protein, and fat, and also the adherence, the follow up, which is very important. Determination and is one thing which we have to, inculcate in our patients, that they should follow what is being told, and that is only going to bring the right result. So I'm happy you have really stressed on this point and shown with results that this is possible. And for us nutritionists, we should always be depending on this particular aspect, lifestyle, MNT, along with exercise and strict regime, not going towards medication, but at the same time not advising not to take medicine, because when the HbA1c is above 9, I think we should tell them to take medications as advised for initial period, and then go over when it comes down to 7, go over to the only lifestyle management and MNT. I think that is your practice also. So we thank you so much for this presentation. And as we are doing the series of inflammation and different condition, we have already done a series on diabetes and different type of diets, and of course the remission we did not touch upon, though we were planning to, but I think you came in right moment to on our platform to uh, take us through this. Thank you so much. I think if there are any questions, Richa can take.
Ma'am, actually, there are no questions in the chat box,
There
except
are
for somebody,
questions. There
Jayashree
are
is asking,
questions.
is HbA1c 12 cure by diet only? So is it only that the intervention through dietary practices has to be implemented? Can it be done with HbA1c as high as 12?
Yeah, I I'm think afraid Haritha can answer.
Yes,
Yeah, Haritha, go on.
please go ahead.
So I think that is the crux of the entire talk, that when you have HbA1cs as high as 12, you do not want to give a false impression to a patient that you can manage it with diet. And by the time they come to HbA1c of 7, a lot of damage in terms of inflammation could have happened and can happen to the patient. In fact, I just before this talk I was talking to another patient who's a very old, patient of mine. And he was somebody who started off with lifestyle interventions, but along the way managed it from an HbA1c of 7 to for several years. But now he was sitting here with an HbA1c of 12 because of so many life events that were going on in his life. and he couldn't focus on lifestyle alone for a long period of time. And that's when we had a very clear discussion, and his doctor put him on insulin, and he brought it down from 12 to 7, but with the help of both diet as well as with medication, in fact, with insulin. So, with HbA1cs as high as 12, it has to be a combination.
Right. So I would also like to ask you one thing. We have been emphasizing on the diet and the medication pharmacological therapy also here. What is about exercises? Are there any typical kind of exercises that you would want to suggest of physical activity? Because if we say exercise, it cannot be that you're doing like 1 hour of exercise or two hours of exercise, and the whole day then you are sedentary and not just sitting around. So that's kind of being inactive. So what are your thoughts about that, Dr. Haritha?
Yeah, I think all of them who want to or whom you want to impress upon that exercise does help. Cardio does help. You will actually see this a lot in GDM. When they go for a walk, come back and recheck their values, you will see a 30, 40 point reduction. So if somebody was at 150, they will show 120 post exercise. That means the circulating blood sugar or a carb that is there in the blood is obviously being utilized immediately for the energy that is required during the activity. So exercise has its own benefit in terms of utilization of excess amount of circulating sugars. If you're looking at what type of exercise, all of us, I'm sure, agree that any form of an exercise that improves muscle, prevents sarcopenia, is the best form of exercise. Traditionally, all diabetics would go for a walk for 1 hour and feel very good and comfortable about it. But today we all know that whatever be the medical condition, we all have to work on the muscle, because muscle is the most metabolically active organ and will help us both in terms of utilization and as an anti-inflammatory organ as well.
Okay, great. I see some hands raised, ma'am. Would they want to be asking questions? There is Ankita Chakrabarti.
You can allow, yes.
Yeah, please go ahead, Ankita.
Ma'am, sarcopenia is a major problem in diabetes, mainly in type 2. So I just want to know one thing. Is a muscle loss? So muscle recovery protein is very much important. But in case of diabetes, patients are always asking for the, ma'am, I can take protein, means non-veg, non-veg. So if I give the patient tofu, but sometimes I am very stressed because patient thyroid level is high. So that's kind of thing. What kind of protein we can suggest if the patient have high glycemic level?
Yeah, I don't think you have to turn a patient vegetarian just to manage their blood sugar levels. You can very well tailor their non-vegetarian intake to a less fat content and still encourage them to eat the protein. Whatever said and done, vegetarians have a challenge in terms of attaining their protein levels unless they're very good at it and very well tailored on a day-to-day basis, which we don't see happening that much. So it's okay to have non-veg, but you should be very sure that you're giving non-vegetarian, which is green, which is white meat, and the frequency of it is what you can regulate. Ultimately, our aim is also to reduce the fat content in the muscle as well. So you, on one side, you want to give protein, but you don't want to give a protein which is high in fat. That's the goal that you can stick.
Okay, ma'am. Thank you so much.
We have Trupta Mehta also. I think she's also raised hand. Do you have any question, Ms. Trupta?
Swati, yes. Yeah.
Swati? Yes, we have Swati Thoda as well, who is raised. Yes.
Hi everyone. Hi Salome ma'am, how are you doing?
Yeah, good. Yeah, go ahead with your question, Swati.
So, ma'am, it's more like I have been working with Fitterfly for some time, and we've been using CGM sensor to try and understand the glycemic variability. Now, having said that, how many people really, in your practice, you've seen that would opt to take CGM sensor to try and make sure that they're able to remit their diabetes?
Yeah, so that's a good question, Swati. While a lot of online programs which are there are very gung ho on CGM. In the general OPD that we see, we are not the ones who are prescribing CGM. If at all, if it is being prescribed, it is being prescribed by the physician. And I classically see that physicians resort to CGM only if they are having challenges with regular management of the diabetes. So if there is brittle diabetes, or if the patient is going into hypoglycemia, or if the patient is having nocturnal hypoglycemia, where, in spite of all the permutations and combinations that they have done with their medication, patient still is going into hypoglycemia, that's when they would recommend both CGM and refer the patient to a dietitian. And that's how we see some of them.
So one more question which comes with this is it safe, or is it rather good for a nutritionist to try and recommend this, or we have to wait for the endocrinologist or maybe the diabetologist to take the first chance to recommend a CGM?
There's nothing wrong in it. If you are able to convince the patient that CGM will help, it will help for both you and me give a better understanding of the blood sugar levels, which is happening through 24 hours. The patient is ready, you convince them, as far as you're not forcing them and you're convincing them and they're ready for it, there's nothing wrong. In fact, even I tried at some point of time, non-diabetic, but still I put a library for 15 days just to see what's happening,
Exactly.
the blood sugars throughout the day. And what I realized was, I thought I will have peaks when I would have a particular meal, let's say you had biryani or you just had plain idli, you would have a peak. But I realized that if you're a non-diabetic, you don't have those peaks. The body manages it, so you don't see those peaks. But the same thing if you see it with the diabetic, very classically they have peaks with, high glycemic index.
Yeah, ma'am. So I mean, over practice, when I realized, some people are ready to try and spend that kind of amount for a CGM sensor. There are others who would want to try for a long length of time, probably not take medication, land up into some kind of inflammation complications, then try a CGM. So I mean, I feel as nutritionists, if we are able to sanely try and push that, it probably helps them to get better faster.
Yeah. One of the arms of better management of diabetes, apart from lifestyle intervention medication, is CGM. So whether it
Yeah.
is continuous or good management of glycemia or repeated checking. So if an app is available and if something like this is available, then why not use it if the patient is for it?
Exactly. I think even the medical management, it is going to help you improve when to change the dosage, especially for the type 1 patients. It's really important because they are the one who will want to, not sometimes give up or sometimes eat or attend parties, young people. And they don't want to also record those readings. They just
Exactly.
want to, and that is the time we can pick up. Even the hypoglycemias are missed out if they don't keep your record or a diary. So it's very good to have CGM as an arm for those who are ready to use it or keep it or affordable. And you should be able to interpret it correctly. That's another thing. It's a challenge.
True, because we've seen, a lot of PCOS, maybe starting with some insulin resistance, having
Yeah.
entered a pre-diabetes, and going between pre-diabetes and non-diabetes ranges of HbA1c. If those are the people who are able to use this, probably it just helps them to not get into frank diabetes.
Exactly. Exactly.
Sure, ma'am. Thank you so much.
So, Haritha, if we have time, I wanted to know those young patients with say 19 or 20 or 30 or say before 30, 40, and if they have a heredity, strong heredity, and they are having 9.710 HbA1c newly detected, have you tried this reversal or let's say remission diet on them? They are young, they have a lot of stress, there are so many factors. So there is always they want to have it, but it's difficult for them to go on a low carb, high protein diet. So is there, you have any experience with such young people?
Yeah, we are constantly seeing young professionals between the age of 25 and 30 who are, young diabetics. Sugars are all over the place. Last week, I saw an individual who had an HbA1c of 12. And he went to the physician and came, but the physician didn't put him on medication. Physician said, I'm giving you 3 months in spite of a high HbA1c because you're a young diabetic and you can reverse it to some extent with lifestyle. But my opinion of that particular case was different, because when I speak to the individual and looked at his general lifestyle, I understood that this guy is not going to remission at all, as you said. If I were the physician for that patient, I would say go ahead, take the medication, bring it under control, and then slowly wean off the medication rather than giving him another 3 months, because this guy had a 2-year history of being diagnosed of diabetes, and he has not done anything about it. So those are not definitely the candidates who we are talking about remission.
Exactly. So this is what I want for these participants to know, that it's not each and every one. Even I had 2, 3 cases like this, where there is a strong genetic history, where there is a lot of work stress, where there is no time of lifestyle and the activity or exercise, and the HbA1c is so high. Initially, we should try to bring it to 7, and then if the person is really determined, then we can think of remission for some time. But yet with the medications, a simple metformin, first line of management initially. That should be the management.
True. Identifying the patient, the right patient, is so very important. My doctor colleague who works in the health check is 58-year-old. He said 10 years ago she saw a slight increase in her HbA1c. She was pre-diabetic at 6.3. Since then till today, she's so careful about her diet that she did not let the HbA1c increase at all. So perfect. I mean, she's done what is ideally required. On the contrary, as you mentioned, a young 29-year-old who's so focused on their career may not really do so.
Difficult. No, even if they want to, it's difficult. So I think we should encourage them to take medication, bring down their HbA1c to 7, and then have a lifestyle and MNT and with exercise and some relaxing exercise, some relaxation. Then I think we can help them out.
Yeah, absolutely.
That should be the remission.
There is one more question, ma'am, in the chat box. Nowadays, there are low glycemic index rice brands which are available readily in the market. What is your view on the same? Because, however, the carb content is similar to that of white rice. So what do you suggest for that?
Actually, I don't want to comment on that. If all of us want to know, we have to do at least some basic, small studies at our own level. They may not be very large ones. The one, I didn't do it on white rice, but we did it on quinoa some time back, when quinoa 5 years ago had come into the market. None of us knew what it was, and they were claiming big claims. So we identified a few diabetic patients within our hospital, and approached about 20 of them and said, see, we're going to cook the meal and give it to you. You just have to eat it and allow us to take your blood sugars every alternate day. So out of that 20, initially 20 agreed, and then only 10 followed up. Then other 10 said, oh no, kaam hai, ye hai, and they did not follow up. But still we followed up in 2 arms. So 10 of them, we just followed up with their sugars, and another 10, we gave them the meal, they came, they ate, and we saw a very good reduction in their postprandial and also a good reduction in their fasting, which I did not expect, actually expect. So there was a good reduction in their fasting value, good reduction in their post-meal value over a period of 1 month. So we just took every alternate day blood sugar check for both the groups. So the group which actually took the meal, understood, did something about it on a regular basis, just for 1 month improved with their glycemia, and they were taking their standard medication. So I don't know whether there are any studies on this low glycemic index rice, because if they are, they would have come out. But in any case, if some companies coming forward and saying that it is available, at least we can see it a few set of patients and get an impression about it before telling patients. Right now, I have not been confident about it.
Ma'am, what are your views on it?
That's what I said. See, 2 meals or 3 meals a day if we are using low GI foods. And how will we make sure that all 3 meals are low GI? Apart from low GI rice or whatever low GI, it's not going to be, and then in between meals. So overall GI we have to consider when we are looking at the glycemic control. So I don't think by just changing what Haritha showed the study, which is like you can add protein or a legumes or a fiber in it. And then that is going to give you a better glycemic control than using a low GI rice.
Right. Right, absolutely right, ma'am. I agree. I was just about to say that Dr. Haritha actually showed in her slide, and she gave a comparison about the brown rice and white rice, and brown rice along with protein. So that was good enough for us to tell that even if we're taking a low GI rice, I think we need to have a combination of rice with pulse rather than including rice by itself, or probably also adding some fiber along with that, so we can reduce the glycemic load of the meal. So great input. Any other questions anybody would want to ask, or any queries? Nothing in the
done.
chat box. Nothing in the chat box.
Thank you. Thank you.
I think, ma'am, can we wrap up?
Yes,
Good
please.
to
Yeah.
wrap up then.
You
Okay.
can give vote of thanks and wrap up. And
Sure.
thank you, Haritha, for giving your time and
Thank
explaining.
you for having me.
this. Thank you
Yeah.
so much.
Thank you.
So on behalf of the whole team of BNA Life, I would like to extend my heartfelt gratitude to each one of you today to have attended the session here. Our esteemed speaker, our expert, Ms. Haritha, for having shared her invaluable insights on the topic and empowering all of us today with her knowledge and skills and strategies to combat this metabolic disorder. Thank you so much for being here. Truly, it was commendable. I cannot really end the session without mentioning a special mention and special thanks to our guru and mentor, Salome ma'am, the brain behind BNA Life altogether, for always sharing her insights, her expertise, and her knowledge on with obviously coming through a huge experience that she holds. Thank you, ma'am, always pushing us towards using scientific evidence-based practices and trying to implement into our practices. And we are all hoping to be a better dietitian and a practitioner with the years to come. Our teammates today who are missing here, Dr. Geeta, Ms. Nazneen, our dear friends who are not there because of some other commitments, our strong back-end team, which we have Mr. Nitin Gandhi, Mr. Advait Date, a special mention to Ms. Vishaka, without whom the programs would not have run so smoothly as they do. So thank you so much, everyone. And I really hope that we all carry forward whatever valuable insights and knowledge that we get to hear and learn on these sites, on these sessions, and we really kind of implement them and take through forward with all of us. We really intend to have more of such sessions, and we are going to be coming up yet next month with another important and critical topic. So thank you so much today for all of you to have attended this. Thank you once again. Have a great evening, and bye-bye from all of us here from BNA.
Thank you. It was great. It was great, Richa ma'am. Thank you,
Thank
sir.
you, Richa. Thank you, Haritha.
Thank you, Haritha ma'am.
Thank you,
Participants.
Mr. Nitin.
And the best part was your complete explanation of look ahead trial.
Yes,
Yeah.
absolutely.
Yeah.
It's such a big trial, and I think you really explained it very well.
Thank you so much. Thank you.
Yes,
Thank you.
It was best of it. Yes, ma'am. Thank you, ma'am. Thank you, ma'am.
Thank you to Mr. Nitin.
Thank you, ma'am.
Thank you, sir.
Bye-bye.
Thank you.
Bye,
Bye-bye.
everyone.
Bye. Thank you.
Bye.
Bye bye.
Yes. So I think I have a PPT.